Good evening, stakeholders. This is Jeremy Obach, lead analyst on this influenza season preparation project. Influenza still kills over 70,000 Americans every year. By analyzing influenza deaths by geography, a data set from the CDC, integrated with population data from the U.S. Census Bureau, we can find insights on when and where to allocate additional staff. Now, despite our advancements in medical technology and vaccines, flu deaths are not trending downward. New strains and mutations make the common flu a perennial challenge. As you can see here, in 2017, we had a total of 75,521 recorded flu deaths, accounting for 0.025 of the 313 million, nearly 313 million U.S. population. Now, despite this accounting for less than 0.1% of the population, we can still improve outcomes by being more prepared when and where flu season strikes the hardest. Influenza deaths do not affect all age groups equally. Vulnerable populations are more likely to develop serious complications and end up in the hospital than the general population. Comprising of the elderly, ages 65 and over, the very young, 5 years old and under, and immunocompromised individuals, regardless of age, HIV patients, patients undergoing chemotherapy, etc. Our study will focus on the elderly component of the population. The very young and immunocompromised are at least comparatively lacking data. And as you can see by this 2017 age demographic split, despite accounting for about a sixth of the total population, we'll see here in dark blue that in most states in the country, ages 65 and over account for the vast majority of influenza deaths. You can see here California, New York, Texas, Pennsylvania, Florida, our top 5 most populous states. Ages 65 and over are the majority of deaths caused by flu throughout our study period of 2009 through 2017. So that begs the question, should we just send influenza additional staffing to the most populous states? We could focus on where most people die from influenza. But with more people usually come more medical facilities and staffing. More interesting, I think, proportion of influenza deaths to total population. Or in other words, the number of people who die from influenza divided by the total population in each state. Now, this is by no means a perfect metric, but with it we were able to compare across the states and see which states are underperforming in flu prevention and recovery for their size. Leading this metric by a wide margin, we have Virginia and Tennessee, just topping 0.25%, with Wyoming in third, dropping down to 0.012%. Now, with a relatively high proportion of elderly, Virginia ranking 7th, Tennessee ranking 14th, it's not a surprise for them to be high on the list. But for them to come first and second, it's likely that there's other factors causing them to underperform in regards to flu death prevention. Ranking dead last in this being in this metric is Utah, whose flu death proportion is below 0.001%. It's a very young state with the second lowest proportion of elderly and presumably has very good outcomes for those who do get hospitalized. Now, in addition to our highest proportion of flu deaths, we also have our highest proportion of elderly metric, in which we can see which states have the highest proportion of old people. Now, for that number, we took the population of each state's elderly proportion and divided that by the entire state population. And first in this metric, we have Florida with 0.179, so approaching 1/5 of Floridians are over 65. Now, interestingly enough, Florida ranks 48th in flu death proportion, which is not what we'd expect based on that elderly proportion. We can hypothesize what that is, why that is, from the weather to medical facilities and so on. Now, on the other hand, we have Alaska, which ranks last in proportion of elderly, but also ranks 7th in proportion of flu deaths. So not only are there not many old people in Alaska, but they are also likely to die from the flu, which makes sense. There's harsher weathers, not a lot of medical facilities, and so on. As this metric indicates, Virginia and Tennessee are our top candidates for benefiting from additional staffing. Additionally, these states in orange, a lot of them seem to be remote: Wyoming, Montana, Hawaii, Alaska, North Dakota. And additionally, some that we'd expect due to a high proportion of elderly, like Maine, which actually ranks pretty well, being 12th, given they have the second highest proportion of elderly. And Wisconsin in 8th, makes sense. As well, South Carolina probably seems to have whatever trend was going on here with Virginia and Tennessee. So that's something to examine further. So we know where we should send our additional staffing. Let's look into when we should send them. So the data bears out a common sense intuition that we're here in America, we're in the northern hemisphere. We have winters around December to February. Winters correlate with colder temps, which correlate with cases of the flu. So for 7 of the 9 years tracked, January had the highest flu death count, as you can see here. Now, inversely, the nadir, the lowest months for most months were in this July, August range. I think August seems to be the lowest in most months. Interestingly enough, the 2 years in which March was the highest in flu death rather than January are presidential election years. So we have March of 2012 and March of 2016. So moving on to our flu death projections for 2018. Fittingly, the highest estimate is for January of 2018, with an estimate of 9.1 thousand estimated deaths, down to our low in August of just over 5,000 deaths. Given this cycle, the window of December through March ought to be the most proactive window in regards to sending additional staff. So, in summary, we recommend that we send additional staff to the top 5 states in proportional flu death, especially Virginia and Tennessee, but also this smattering of remote states: Wyoming, North Dakota, Alaska, Montana, etc. But also these southern states, additional southern states of South Carolina, and noted elderly states, Wisconsin and Maine, actually ranked pretty well considering, but still worth our attention. Whenever practicable, it makes sense to send them from states that are neighboring but also had very low flu proportion. And we should also attempt to send as many as we can in this peak season, December through April in the States, with expected spikes in January. So next steps, we have an exit survey and gathering data to assess the effectiveness of additional staffing measures for the 2018 flu season. We should also gather data on existing facilities and medical staffing levels across the states to see in a quantifiable way who is the most prepared on a facility and staffing level baseline. And also examine the medical practices and flu vaccination rates of the states with the lowest and possibly also the highest flu death to population ratios. Now, key performance indicators as we investigate into this next year: monthly influenza death count being comparable or lower to the corresponding month of the 2017 year, and a total influenza annual death count of less than 70K would be a major indicator of success for our additional staffing measures. I appreciate your time and attention. Please contact me via email with any questions or concerns. Thank you for your time.